Everybody's okay, I guess we'll get started so everybody's on their good timeline. If the slides are not moving, please let me know and I'll have Karima help me out. So today we'll be talking about pharmacokinetic in kidney diseases. What I tried to do today is we'll be talking about some of the pharmacy and pharmacokinetic principles that are used in medication dosing in our special patient populations of kidney disease. I will not be talking about dialysis removal for medication because that is something I usually cover in a toxicology lecture where we talk about a two-part toxicology lecture for dialysis and toxicology of the medications. It is, gosh, not working for me.
I think we scroll up and down.
No, I mean, usually when you, next step, okay, it's working now.
Okay.
Okay, sure. So the objective today we'll be talking about pharmacokinetics and what is pharmacokinetics, how do we use it in medication dosing. Pharmacodynamics, what does that mean and what numbers do we use? How does chronic kidney disease affect the pharmacokinetics and the pharmacodynamics of medications? How to estimate kidney function for application to pharmacokinetics and pharmacodynamics. And then we'll talk very shortly about some nuances for anticoagulants, for antibiotics, and then some other examples. So polypharmacy in kidney patients is actually very common. Kidney patients tend to have multiple comorbidities, and there is usually increased medication burden in patients with CKD, so much so that 80% of our patients take 4 medications or more on a regular basis. And for dialysis patients, the median number of pills is 19 pills a day. So there's a lot of chances of medication interactions and alterations of medication effects. Okay, it is really not moving as speedily. Yeah, there is a little lag in the system. So let's move on to pharmacokinetics and pharmacodynamics. So what is pharmacokinetics? So pharmacokinetics is the study of what happens to a drug after we give it to a person. So let's say we give an infusion or any medication to a patient. The medication level first goes up in the plasma or the serum. After that, it is distributed, then metabolized, and then eventually the levels of medication will fall off over time. This is called pharmacokinetics as to what happens to the medication levels over time. Pharmacodynamics, on the other hand, is what effect does the medication have on the subject. So what we're talking about is effects of all kinds, therapeutic effect as well as adverse effects. And how do we measure them? So these highlighted numbers are what we use for pharmacodynamic evaluation. So for example, Cmax is the maximum concentration of the medication achieved after a certain dose. Okay, so Cmax is the maximum concentration of a medication achieved after a certain dose is given. Area under the curve is basically just the whole area under this curve, and we will talk about as to what that means and why that is important. And then there is a duration of effect. So what this dotted line is showing is the minimum inhibitory concentration or the minimum effective concentration. What that means is, what is the minimum concentration of an antibiotic, for example, in the serum or the blood, that will be able to kill the bacteria or inhibit them. So we need to know what is the duration of the medication for a concentration to be kept above this level. And that actually gives an idea about medication effect as well. Now, so this here shows the timeline after medication infusion that the medication level will be reduced by 50%. So this is basically T50. This is the time that the medication will take for a 50% reduction in concentration. Then there is a duration of effect we talked about where, especially for antibiotics, you want to know what is the total duration of the medication that is above the minimum inhibitory concentration. And then we have the C minimum, which is the minimum concentration of the medication at which we have to consider does the patient need the second dose. In our common parlance, we use this as a trough level. So when we are talking about giving the patient, doing the trough level on the medication, for example, Dr. Alam probably will be ordering tacrolimus trough dosing. We are checking this level. We're talking about the minimum level before we are considering the next dosage. This is the duration, especially important for antibiotics. And this is the T-half. Why is T-half important? Because the T-half determines this, the steady dose of medications. Typically, any medication will need 4 to 5 dosing cycles to achieve a steady state, and you do that for calculation based on the t-half. So a medication has a short t-half. You will need more frequent dosing to achieve a steady state at 4 to 5 cycles. A medication with a long t-half, you will need less frequent dosing to determine the steady state level. If you keep giving medications without determining their t-half, then there's a possibility that you might just keep increasing the Cmax and get more adverse effects. These numbers are also important because these are very particular to the medication under study, and these are determined very early in drug development. So, for example, antibiotics, let's talk about beta-lactams. So, beta-lactams are a medication. Their effect is dependent on the duration of the medication level. So, for example, if you give a beta-lactam, where they are cell wall inhibitory medication, there needs to be this level achieved above the MIC for the bacteria to be kept controlled. On the other hand, the adverse effects of beta-lactams, for example, confusion that we see with cefepime and zosyn, is actually dependent on Cmax, which means if you were to give a patient a beta-lactam antibiotic, you want to avoid too high concentration, but you want to prolong the duration that you have above the minimum inhibitory concentration, which means in a patient with kidney disease, where their clearance will be affected, you will reduce the dose of the medication, so you avoid too high Cmax, but you will keep the duration the same. So you will reduce the dose, but give the medication at the same frequency. Now, this is different, for example, for aminoglycoside antibiotic, where the effect of the medication is actually concentration dependent. So, and the aminoglycoside, how quickly they kill bacteria depends on the Cmax. And their adverse effects actually depends on the trough dosing. So aminoglycosides are flip of beta-lactams. You want to have a good Cmax, so you actually have bacterial killing, but you want to avoid long exposure to the minimum inhibitory concentration to avoid toxicity. So for aminoglycosides, what we do is you keep the dosing the same, even if the clearance is reduced in kidney patients. You keep the dosage that you give the same, but you prolong the duration at which you give the antibiotic dose. Right? So that way you are avoiding high in trough levels, but you're keeping the C maximum. A third example is vancomycin. Now, vancomycin killing actually depends upon the dose and the duration both. So what do we do with vancomycin? So for vancomycin, we actually calculate the area under the curve, because the area under the curve is the best mix of what concentration you have over what time. And the area under the curve, so it is actually area calculation under this curve. You can imagine this is a triangle, this is a triangle, and there is a assessment. The area under the curve for vancomycin is what determines the vancomycin effectiveness. So particularly for vancomycin dosing, we actually have a formula here that we use in our pharmacy department, and they calculate the area under the curve. So vancomycin dosing is dependent on both the duration and the timeline. And that's why we check a trough level and a peak level for vancomycin. You will see they calculate the area under the curve and they determine the dose as well as the duration based upon the area under the curve. So concentration dependent Cmax is the key. For example, aminoglycoside. Time dependent killing for medications. We need to keep the drug level more than minimum inhibitory concentration. And examples of this is vancomycin and fluoroquinolones. So how does chronic kidney disease affect these pharmacokinetics now that we understand what this curve actually means? Well, it can affect in multiple ways. It can affect by affecting the absorption of the medications, distribution, metabolism, elimination, and then prolongation of the half-life of some renally cleared drugs. And we will go over these individually. So absorption in chronic kidney disease can be affected by certain exogenous factors. So for example, in diabetic patients tend to be common in kidney disease, and when they have gastroparesis, it can actually alter the absorption of the medications because those patients, the medications, they stay in the gut at that pH for longer. Very individually medication dependent. Medications that are absorbed in acidic pH might be absorbed for a longer duration in patients with gastroparesis. On the other hand, we all know that there are bowel edema that can happen in patients with kidney disease, especially if they have fluid overload. And I'm so sorry, this is showing a different on the system over here compared to where I created. And so bowel edema can affect, for example, the absorption of Lasix can be affected by as much as 50%. So So in patients who have nephrotic syndrome, cirrhosis, congestive heart failure, volume overload can affect how these medications are affected. Not directly a kidney effect, but because of the edema or the disease in kidney. And then there is potential for drug-drug interactions. So for example, in our late-stage chronic kidney disease patient, we often use calcium-containing phosphorus binders. These medications can alter the gastric pH. At the same time, they have a potential for binding the medications directly, just like they bind the phosphorus. And we have to be cognizant, and in that case, we might have to distance these medication dosing from other medications. Let's talk about distribution. So how is distribution affected in CKD and medication dosing? So in our kidney disease patients, especially their conditions where they're getting swollen, there is an increased volume of distribution in patients with their metastasis state. At the same time, kidney disease patients, because of different pathophysiology and also because of anorexia, are highly likely to have low albumin level, and that can increase the free fraction. We will talk about both of these in a bit of detail. So what is volume of distribution? So volume of distribution is the amount of water volume in which a medication distributes itself after a certain dose. So for example, in this cartoon here, if somebody is given 10 milligrams of a medication, and let's imagine the total body water, not just blood or plasma, the total body water is 1 liter, then the final concentration that you will achieve is 10 milligrams per liter of this medication. So concentration is the amount of dose by the volume in liters. Now, this will be affected by other things. So for example, not shown here is, let's say if a medication is highly tissue bound to a certain tissue, then in that case, that small amount of tissue might absorb a whole lot of this medication, and you might end up with a lower concentration of the medicine, even though the water volume is the same. So it will be apparently seen as increased volume of distribution for that medication, whether those medications are tissue bound or they're bound to certain proteins, right? Why we're talking about this over here is because if a medication's volume of distribution is affected, then we may have to dose the same medications in a different way. So for example, if you're talking about medication like aminoglycosides, where the effect is dependent on the C maximum, and the patient is edematous, now your volume of distribution is more, you might have to give the same dose or a more dose to achieve the same Cmax. But because the adverse effects are trough dependent, you might have to dose the medications less often to avoid the trough effects. So it's very, very individually medication dependent and depends on their volume of distribution. So something we also need to pay attention to, especially in patients with super metastasis states. So talking about the left side, like I said, initial dose is that's why similar to the patients without kidney disease, even though they have high volume of distribution, because we want to keep the same C maximum. But the maintenance dose is lower, and we keep the extended period for those medication dose to keep the trough levels low to avoid the nephrotoxicity. So similar doses for trough levels, and this is something that sometimes is difficult to understand, that in our patients with kidney disease, even though aminoglycosides have nephrotoxicity, why are we doing at the same 80 milligrams that we do for patients with normal kidney function? It is because we want to keep the C maximum as achievable as possible. Now, whenever there is a rule, there is an exception. So exception of this is digoxin. So digoxin is actually a hydrophilic molecule, which means it loves water. It distributes in the total body water of the body. Still, the volume of distribution of digoxin is lower in kidney disease, even with the metastasis state. And why is that? So digoxin binds to sodium potassium ATPase. That's where its mechanism of action happens. And sodium potassium ATPase is bound in muscles as well as cardiac myocytes. So when digitalis binds the sodium potassium ATPase, what it does is it increases the sodium concentration inside these cells. Because of the sodium concentration, there is release of calcium from the sarcoplasmic reticulum. And the calcium then, of course, binds to the muscle proteins and increases the inotropy of these muscles. And that's how it actually works as an inotrope in the heart. In our kidney patients, usually because of their decreased appetite, kidney patient tends to lose weight over time, which means their muscle mass might be lower compared to previous years. In that case, the place where digoxin binds with the sodium potassium ATPase is actually less available because they have less muscle mass, which means even though they are edematous, the volume of distribution of digoxin goes down because the muscle is where the medication dissolves, spreads itself and binds. So in kidney disease patients, even with that metastasis state, digoxin, a hydrophilic molecule, tends to have a lower volume of distribution, and we need to pay attention because we have to dose down these medications, even for the initial dose as well as for the maintenance dose. So digoxin is special. So the volume of distribution rule doesn't apply for digoxin. So hydrophilic drug with a very large volume of distribution in healthy individuals, because of sarcopenia in patients with kidney disease, there is a decreased affinity for digoxin because of competition with uremic toxins. At the same time, because there is reduced tissue binding available, more drug remains in the systemic circulation. So more potential for toxicity, even with less effect at the same dose if we were to give them without kidney disease. So let's talk about protein binding. So a lot of the medications are bound to albumin. And trying to show in this picture, there is albumin, there is a bound fraction of the molecule that is bound to albumin, which is in equilibrium to the free drug. A lot of the medications that are protein bound, their effect comes from the free drug levels, which means as well as therapeutic effect, as well as the adverse effects are dependent on free drug. In patients with kidney disease who also have hypoalbuminemia, even at the same dose given of medication, less medication will be bound and more medication will be available free. Right? Same dose of medication given, because there is less albumin, bound fraction will be low, and the free drug will be more available, which means the potential for treatment as well as the potential for toxicity will be higher in hypoalbuminemic states. So more free drug is available for the same total drug level. So the same dose given, total drug level is the same, but there is more free drug available. And this can be implicated, for example, in dialysis, which is an antibiotic medication. When patients are given dialysis and they have hypoalbuminemia, the total level of dialysis might be the same, but the free level could be therapeutic or toxic, even at the lower total concentration. So, and this is sometimes seen that the patient will come with dialysis toxicity clinically, even though they have a normal total dialysis level, just because they are hypoalbuminemic and the free drug level is more. So medications that are highly protein bound, in those medications, it is recommended to check both the total as well as the free drug level, because that will give you an idea about the effect of hypoalbuminemia on the total level. At the same time, the free drug level is what manifests as therapeutic as less toxic level. Is that clear? Is that confusing? Okay, so for hydrophilic medications, medications that distribute in the total body water, we need to usually dose the medication same or at higher level because of the edematous state. But we also need to know where does the medication actually bind, because that part could be less available. For medications that are protein bound, we need to check total as well as free drug level, so we have an idea about what dosing to give and what free level we are achieving to avoid toxic effects even at normal total levels. Let's talk about metabolism. So metabolism of medications sometimes is dependent on the reduction in kidney function. Now, it has been seen that in patients with kidney disease, even if they do not have liver disease, the kidney toxins and the uremic toxins can affect the hepatic enzyme activity. And depending on the particular enzyme in question, hepatic enzyme activity can be reduced by as much as 5 to 50%. So even if the medication is metabolized by the liver, the uremic toxins can inhibit the hepatic metabolism, especially if they're dependent on P-glycoprotein. So kidney disease patients, even though they were metabolized medications, we sometimes have to check the level of those medications to monitor for toxicity effects. Also dependent on metabolism is the accumulation. And when we say accumulation, we are talking about the accumulation of medication if the drug has not been dosed differently. As well as we also have to understand what are the metabolites of the medication and the vehicles that the medication is carried in. So what does that mean? So a medication often is a prodrug. And in our body, some medications will be metabolized to the active molecule. So knowing from the previous slides that the hepatic enzyme metabolism can be affected in kidney patients, the kidney clearance can be affected in kidney patients. We also might be needing to measure or be at least careful about the metabolites of medications that are given as prodrugs, which means we might have to have more sophisticated methods of measuring their effect rather than just a total drug level. Also important is vehicles. So vehicles are the components of a medication that helps the medication be more stable. So for example, cyclodextrin is what is used as a vehicle in intravenous voriconazole and posaconazole. So intravenous voriconazole and posaconazole is not stable on its own. Cyclodextrin is used as a solubilized agent, so these medications can actually stay on the shelf for longer. Same as we know, propylene glycol is a vehicle for intravenous lorazepam. What happens is, in patients with kidney disease, even if the primary medication may not cause a problem, sometimes these vehicles will accumulate, and these vehicles can have toxic effects. So something to watch for. So we know that propylene glycol in intravenous lorazepam, and this is often a board question for the fellows, will actually give metabolic acidosis. So when patients are given intravenous lorazepam in kidney disease, or if they are ESRD patients, propylene glycol can actually give you a metabolic acidosis. What happens with cyclodextrin? Cyclodextrin is actually known to cause phospholipidosis. So this is an example of phospholipidosis in posaconazole, rare in humans, but very often shown in animals. So when posaconazole is given to people, the cyclodextrin vehicle in posaconazole can actually affect the epithelial cells as well as the podocytes and lead to deposition of phospholipids in these cells. So this is an example. This is a podocyte, and they are showing a lot of phospholipids development in the podocyte, and this patient came with proteinuria. Now, it's interesting because these phospholipids they look like laminated appearance in certain other kidney diseases, but yeah, this is actually because of the cyclodextrin. And last, the elimination of medication, and that can lead to prolongation of the half-life of renally cleared drugs. It's self-explanatory that medication is cleared by the kidneys. Then depending on the kidney function, if the kidney function is lower, the medication will be cleared less, and the medication effect can last longer. So with that, the next part is that when we talk about pharmacokinetics and pharmacodynamics for medications, how do we apply our kidney function estimations? And this is something to know. So estimation of kidney function properly is a problem, especially when it comes to pharmacokinetics, and let's see why that is. So let's read a question. An 82-year-old woman is admitted to the hospital with a urinary tract infection and failure to thrive. She weighs 120 pounds and is 5 feet by tall. Her serum creatinine concentration today is 1.4 milligram per deciliter, and it is stable. She has a history of hypertension, type 2 diabetes, hypothyroidism, and atrial fibrillation. Which of the following statements is correct regarding drug dosing adjustments in this patient? Should be based on her estimated GFR, which comes out to be 35 milliliters per minute per 1.73 square. Should be based on her individualized GFR, which is calculated at 32. Should be based on her estimated creatinine clearance, which comes out to be 27, or the best kidney function estimate to use depends on the drug and what is recommended in the approved package labeling. So let's go over these terms so we know what these exactly mean and why we are talking about this. So what is estimated glomerular filtration rate? So estimated GFR is an estimation of course, the glomerular filtration rate that is done using some standardized formulas. So as of now, we estimate the GFR mostly using the CKD equation, and previously we have also used this using the MDRD. Now, these are complex equations, but there are calculators available online, and that can be used. These depend, for example, the CKD depend on the serum creatinine, depends on the gender. The race has been taken out of these equations, so basically this part does not exist anymore. So use the CKD and MDRD, the same formulas without a race adjustment. These give us an estimation of the patient's GFR. Also to know, CKD-FE as well as MDRD were developed from people with normal kidney function. So they tend to be less accurate on the extremes of the kidney function, but still helpful. So that's estimated glomerular filtration rate that we are most used to in our clinical terminology and clinical parlance. What is individualized GFR? So what we just saw from the equations, we calculated eGFR, that eGFR is actually reported as milliliters per minute per 1.32 meters square body surface area. So there is this variable that comes out in that report. Again, the eGFR that we calculate from CKD-FE and MDRD is milliliters per minute per 1.32 meters square body surface area, which means if somebody has a different body surface area, their GFR should be different. So what we do with individualized GFR is we calculate the eGFR using the CKD equation. Then we calculate their body surface area using different formulas. The combination one is the muscular formula. And then we normalize their estimated GFR for their body surface area to give that patient's individual GFR. So let's take an example. Oh, before that, sorry, the muscular formula. So what is the muscular formula? Muscular formula is body surface area is the square root of height in centimeters times weight in kilograms divided by 3600. So also there are apps available for this. So let's take an example. I'm an extreme patient, which is 160 kilogram. Height is 175 centimeter, and the estimated GFR by CKD is 60. So when we calculate the body surface area would be 175, which is the height, times 160 kilograms, which is the body weight, times divided by 3600. The body surface area is 3.8 meters square. Now we know the GFR is 60 milliliters per minute per 1.73 meters square. So when we normalize it for this person's body surface area, the BSA adjusted GFR will be estimated GFR divided by 1.73 multiplied by the patient's body surface area. Make sense so far? So when you calculate this, the BSA will be 60 times 2.8 divided by 1.7, and the GFR calculates at 97. What's remarkable is the difference. This patient's CKD GFR came out to be 60, but when you normalize it for their own body surface area, his GFR is 97. See the difference? Yeah. So that's individualized GFR. And for our patient, when you normalize it for her body surface area, given the height and the weight, it actually comes out to be 32. Now, not a huge difference, but it's still a difference nevertheless. And what is creatinine clearance? So creatinine clearance is calculated using some other formula, and the commonest one is the Cocker-Gall formula. So Cocker-Gall formula is a rather old formula that was developed when the creatinine measurements were not standardized, and you could actually have variation between that form and question different labs. But anyhow, creatinine clearance using Cocker-Gall uses the age, lean body weight of the patient, and the serum creatinine. And then we do use a formula for gender, basically gives you an estimate of GFR using creatinine clearance. And why this is important is because, so question is, we have too many measures of kidney function here. Estimated GFR, individualized estimated GFR, creatinine clearance, and which one should be used? So MBRD and CKD are the recommended equations for staging of chronic kidney disease, and that is what we as clinicians use in our daily prevalence and in our outpatient as well as inpatient populations if they have standard creatinine. However, the Cocker-Gall formula, which gives you a creatinine clearance, is the most common equation that is used to calculate creatinine clearance for pharmacokinetic data. So previously, when a lot of these medications that we use today were developed, their pharmacokinetics and pharmacodynamics were calculated using Cocker-Gall formula-based creatinine clearance. Why that is important is because now we have a clinical pharmacological disconnect. So we actually calculate using CKD, which sometimes gives a very divergent GFR than what the pharmacists get using creatinine clearance, which means the terminology we are using is different from the terminology that the pharmacist is using. And that sometimes leads to a little bit of misunderstanding. The FDA recently released a pharmaceutical guidance recommending the use of individualized GFR for drug dosing. So for newer drug development, they are recommending to use CKD eGFR calculation. But then when we are using them on individual patients, they want us to calculate their body surface area, calculate their individual GFR, and determine the drug dosing based upon their individual GFR. Because as we saw, the individual GFR can be way different from what we are calculating using CKD epi. That will actually give you a lot more individualized pharmacotherapy for our patients, especially more complex patients and patients in the ICU. As of now, the CKD epi is the creatinine equation that the FDA recommends to be the preferred option for eGFR calculation. But while this happens, it is unlikely that for some of these older medications, for example, digoxin, that we are going to have any more data. So for the time being, the best kidney function estimate to use depends on the drug and what is recommended in the FDA-approved packaging label, because it depends on what was studied when this drug was developed. Make sense? So different formulas for estimating different kind of kidney function, and hopefully in future we'll be calculating individualized GFR. So when you see that term, you know what it means. Now let's go over some of the medications as quick examples. I will not bore you with individual dosing because that's something that can be easily found.
Dr.
Yes,
Rathi.
sir. Yes.
Yes, I have a question. So what's the answer for that individualized GFR is the best for the patient? You said the 80-year-old.
So here the answer is that the best kidney function estimate depends on the drug and what is recommended in the package labeling. Because for different drugs, the package labeling in future might be different. Right now, for most of them, it is creatinine clearance. So the pharmacists actually use Cockcroft gauge for calculating creatinine clearance. They do not even look at our GFR. And as it happens, I had a big talk with Justice Shanks the other day. Their Cockcroft gauge is actually not reported anywhere in the chart. So you could be actually very much trying to understand why the medication was dosed in a certain way. It is only in their notes and their formulas. So as of now, we are actually going by the medication labeling. For example, the newer medications that are coming out in the market, if they follow the FDA guideline, we might actually be seeing eGFR from CKD epi as the determinant of their drug dosing.
Okay. So it depends on the drug basically, and what's the packaging.
I'll give an example of Priasa, SGLT2. They do not talk about creatinine clearance. They're actually based upon eGFR. So for example, SGLT2, the recommendation is to start SGLT2 when the GFR is about 20, not creatinine clearance. So for new medications, more and more data is coming out based on GFR.
Okay, thank you.
Does that answer your question?
Yeah. Thank you.
So we have to pay attention to see what I'm saying because it's going to be confusing in future based upon what is recommended for one particular medication. Okay, let's talk about anticoagulants. You want to read?
A 72-year-old man presents to the hospital with RVR, heart rate 130 to 139 beats per minute, and new onset non-valvular atrial fibrillation is diagnosed. Patient's medical history is significant for type 2 diabetes, hypertension, dyslipidemia, CKD, GFR category 5, based on eGFR of 12. The estimated creatinine clearance using the Cockcroft formula is 14 milliliters a minute. The patient had a CHA2DS score of 3, and anticoagulation is being considered to reduce the risk of future stroke. Based on different pharmacokinetic dependence on the kidneys for elimination, which of the following direct-acting oral anticoagulants would be the best recommended for this patient? Dibicatron at 75 milligrams orally BID, edoxapan at 30 milligrams orally daily, apixaban at 5 milligrams orally BID, and rivaroxaban at 20 milligrams orally daily with dinner.
Right. It's difficult to remember all of these, and that was not my intention, but let's talk about it. So anticoagulants, so DOACs are used more commonly than Coumadin at this point of time now. So DOACs differ significantly in their renal clearance. So quickly about warfarin, the tissue sensitivity for warfarin in kidney disease increases as the kidney disease progresses. As it happens, the bleeding risk and calcifilaxis risk also increases. So for warfarin, particularly when we are dosing it in patients with kidney disease, it is very, very important that we check their INR. But in patients with stage 5 kidney disease, as well as patients on ESRD, warfarin is not a recommended anticoagulant, especially for atrial fibrillation. DOACs are. So out of the ones that we talked about, apixaban, which is a DOAC, is the preferred medication in CKD5 and hemodialysis. Why? Because it has the lowest renal clearance, as we'll see in the next slide. And also what about unfractionated heparin? Unfractionated heparin is actually not renally cleared, and also important to know, unfractionated heparin is not significantly removed by dialysis. But why it is safe is because it is still more predictable. And at the same time, we also have a reversibility. So if you have a patient where heparin is working too much, we actually have protein that can actually be administered to undo the effect of the heparin in a more calculable fashion without too much difference. Heparin is cleared by the reticular endothelial system, so not kidney dependent. But out of the DOACs, dabigatran is 80% kidney cleared, which means in patients with advanced kidney disease, dabigatran becomes very unreliable. So dabigatran is to be avoided in patients with CKD4 and CKD5. Edoxaban, which is Sabesa, is 50% renally cleared, so also is to be avoided in late-stage CKD. Rivaroxaban, which is Xarelto, is removed anywhere from 36% to 40%, but apixaban is 25% removed. And therefore, because apixaban has a more predictable and limited removal in kidney disease patients, this is considered to be the best option for patients with kidney disease 5 as well as ESRD. So, the intention for that medication, for that question was to understand that apixaban is the preferred anticoagulant in patients with CKD5 and in ESRD when it comes to atrial fibrillation. Coumadin, whenever possible, less reliable. Other medications based upon their renal clearance also becomes less predictable. Let's talk about antihyperglycemics. So, antihyperglycemics, metformin is recommended to be avoided if the creatinine clearance or the GFR is below 30. Why? Because the lactic acidosis risk increase. A lot of the patients ask whether metformin causes kidney function worsening. The jury is out of that. They have in small studies that tend to claim that metformin can cause kidney injury, but it is not yet completely determined. So as of now, what we are worried about is the lactic acidosis risk, which increases when the GFR is below 30. So we don't start it, and if the patient's GFR goes below 30, we stop metformin. SGLT2 inhibitors have cardiorenal benefits. Now, as per the labeling, we use SGLT2 inhibitors if the GFR is 20 or above. But once you start those medications, you can continue them forever for their cardiovascular benefit. It is to be noted that SGLT2 inhibitors, the hypoglycemic effects actually does go down with GFR. So SGLT2 inhibitors work on the proximal tubule, on the SGLT2, of course. So if there's not a significant GFR, medication is not delivered to the proximal tubule, and their hypoglycemic effect actually goes down. It seems like they have some other pluripotent benefit on the cardiac and on the cardiac tissue, and that's why they still reduce the cardiovascular diseases in these patients, but that seems to be independent of the hypoglycemic effect. So that's why SGLT2 inhibitors can be started GFR 20 or above, but continued indefinitely. DPP4 inhibitors, for example, Januvia, requires dosing changes, and there is actually a stepwise decrease depending on the GFR. If the GFR is below 20, below 25, you reduce by 50%. If the GFR is below 50, you can reduce the dose by 25%. Insulin is a very large molecule, and insulin dose sometimes need to be reduced as much as 30 to 40%, depending on the patient's GFR. And this may need expert consultation with endocrinology because insulin clearance tends to be less predictable in patients with kidney disease. And because of the urinary milieu, they also tend to be more insulin resistant. So we have two different ideas coming up in patients with CKD, and that means much more individualized treatment. Okay, antibiotics. So 66-year-old man is admitted to the hospital with a Staph aureus bacteremia without evidence of endocarditis. The culture sensitivity report indicates that Staph aureus is obsessed and insensitive. He has a medical history of uncontrolled hypertension, dyslipidemia, polycystic kidney disease, and receives intermittent hemodialysis on a Monday, Wednesday, Friday schedule. Internal medicine team would like to switch the patient from IV vancomycin to cefazolin for a 4-week total course of antibiotic. Which of the following should be advised the internal medicine team about the dosing of cefazolin in this patient? Cephalosporins demonstrate time-dependent pharmacokinetics. Therefore, reducing the maintenance dose and keeping the dosing interval close to normal is ideal. Or is that cefazolin is unique in their prolonged half-life in patients receiving maintenance hemodialysis, which allows for 3 times a week after dialysis dosing. Is it cephalosporins demonstrate concentration-dependent pharmacokinetic characteristics, therefore keeping the normal dosing, but increase the dosing interval? Or IV vancomycin will be preferred over cefazolin in this patient because of more convenient dosing and the options for therapeutic drug monitoring. So, too much information over there, but basically, cephalosporins demonstrate time-dependent pharmacokinetics, and that does seem to be true. Cephalosporins do not demonstrate concentration-dependent pharmacokinetics. That is aminoglycosides, for example. So this option is incorrect. Cephalosporins is unique in that their prolonged half-life in patients receiving maintenance allows 3 times the dosing, or is it just we should just give them more vancomycin? So let's see. So beta-lactams, as we talked about previously, the treatment effect of beta-lactams depends on the duration that the medication is above the minimum inhibitory concentration. The toxic effect actually depends on the Cmax, which means in a patient with less clearance, we will want to avoid too much at the time dosing. It will make sense that we keep the dosing maybe the same if they have increased volume of distribution, but you increase the dosing interval, right? So this is just a unique thing that in patients with sabazolin and cefepime tend to have much longer half-life in patients with ESRD. In fact, it is renal clear medication. Patients with ESRD who don't have significant kidney function left, medication will actually hang around forever until it is cleared by dialysis. So in patients with ESRD, cefazolin as well as cefepime in two unique situations can be dosed after dialysis. So there's renal removal is the primary clearance. Hemodialysis removes the medication significantly, and therefore we just dose them after dialysis. That way, we are dosing them less frequently, avoiding the C maximum, and we are having less side effect, but a prolonged MIC concentration. So beta-lactams adjust the dose, not the interval. Aminoglycoside, usually we do extended interval preference, and that is what is done in our hospital as well. Vancomycin, as we talked about in the first few slides, we calculate area under the curve because they are dependent, their effect is dependent on dose as well as duration. The area under the curve guided monitoring essentially. So I want if anybody knows, and when these patients come to dialysis units, there is no way for us to check a peak level. So I was actually wondering if anybody knows in their applications, do you all check a vancomycin level in our dialysis patients who come to the clinic with a vancomycin monitoring request? And how do you use that information? Dr. Asa, Dr. Lam?
Sorry, I mean, are you asking about vancomycin?
Right. So vancomycin is the treatment effect is actually dependent upon dose as well as duration. That's why in the hospital, what the pharmacists do is they actually determine an initial dose based upon the body weight, and then they calculate a peak, they measure a peak and a trough, and they calculate the area under the curve. And further dosing and timing is determined based upon the area under the curve. But you know how sometimes we get patients in the dialysis unit with vancomycin requests, and infectious disease want us to check vancomycin level. So we usually check it before dialysis, which is a trough level. But how do you use that level? What do we do? You get any idea what do we do with those levels? Because with the
In the
latest
past,
information, it's saying
they have
those levels
been,
are completely useless for us.
yeah, they have been doing trough levels in the past, like 15 to 20, aiming for 15 to 20. Nowadays, I think, in the hospital setting, they're trying to do AUC kind of calculations.
Right.
But obviously, in the outpatient setting, it's not practical.
Right. So I wonder if we are actually taking more side effects in our dialysis patients because we are keeping the trough level above the therapeutic margin.
But there's no other way to do it.
To look into and study.
But it's harder to do it, right? As Dr. Alam said, the only
Yes.
thing you can do is the trough and actually.
Correct. Because nobody stays until 2 hours after dialysis for peak level, right? So, yeah.
Yeah. I mean, you calculate the initial dose, and then after 3-4 doses, after the half-life, like 4 half-lives you got, probably you just check the level, and if it's 15 to 20, then, you adjust the according to it, actually. You go with the weight initially, weight of the patient, calculate
Right.
some dose, and then see if it's actually 15 to 20.
Right. So I'm wondering, and I talked to the pharmacy here, for ESRD patients who get started on vancomycin in the hospital, maybe they can actually have a more standard protocol that they tell us what dose to send on dialysis as an outpatient, because in the hospital, they have some peaks and troughs, hopefully, to calculate that dosing.
No, but we already do that, right? The case manager usually sends the prescription to the dialysis unit. What's the latest once we achieve a certain level, for
Right.
example, if you need 6 weeks of antibiotics for the endocarditis, we go with whatever the last dose the patient got in the hospital
dose
from the pharmacist. Yeah.
Right, that makes sense. We go with the last effective dose. Yeah.
Some guys, patient was in acutely sick,
Right.
and then now they more like volume optimized. So
Exactly. So how does that affect their treatment levels? Right.
yeah.
Yeah.
And so usually you check the level. What do you do with the
So let's say the patient is getting treatment for endocarditis or osteomyelitis, and the treatment level is 20 or above.
Yeah.
Which means if we do what we currently do in the dialysis is we do a pre-dialysis level, and let's say if the level comes out to be 15, then we usually increase the dose by that 20% margin.
To get to the.
Yeah, to get to the 20. But what I'm saying is, because the toxicity is actually also peak dependent and trough dependent. Vancomycin is the effect is dependent on peak as well as trough at the area and curve. Same for the toxicity of vancomycin. We might be taking more chances on the residual kidney function because we are giving them probably higher peaks.
And there's no way to.
And there's no way to check it, right? Okay. Dialysis layers of the drug. So this is something I will not be going into detail because that is something we talk about in another toxicology lecture. But very briefly, when it comes to kidney replacement therapy removal of medications, what we remove with dialysis therapies are medications that have low volume of distribution, so they have limited water distribution, they are not significantly tissue bound, they are hydrophilic, so they are basically water soluble. Medications that are lipophilic will be bound to plasma membrane and lipophilic tissue and adipose tissue and not available for dialysis. Low protein binding, because dialysis will be removing medication that is free. If it is bound to protein, then that is a huge molecule. It's arguably bound with several drugs, and dialysis is not able to remove them. And of course, if they have a small molecular weight, because dialysis filters tend to have molecular weight cutoffs, you can only remove items that are beyond, that are below a certain molecular weight. So medications that are dialyzable are medications that are hydrophilic, so love water, and they have limited volume of distribution with low protein binding, and preferably smaller molecular weight. So that's very quick on what is removed by dialysis. And that's my lecture. Thank you so much. Any questions?
Oh, sorry.
Thank you. Great talk.
Thanks, Dr. Rathi.
Thank you. Appreciate it.
About any questions, but
Thank you.
like really
Dr.
full body mass index, like squat.
Dr. Rathi.
Yes. Yes.
Yeah, it just I didn't get the answer for the anticoagulant lady to adjust. Which choice is like the answer? Is it like you mean is Apixaban or Eliquis is the best choice for CKD or what's the? I mean,
So for
what's that
CKD, for CKD 5 and end-stage kidney disease patients, Eliquis, which is Apixaban, is the preferred oral anticoagulant.
Yeah, okay. So the dose is the same, like 5 milligram a day.
So the
twice,
dosing
or should
for
we
right, so the
reduce the
dosing
dose?
is 5 milligram twice a day, but as you know, Apixaban dosing also depends on the patient's creatinine, body weight. So there are 3 criteria, and if the patient needs 2 out of 3, then you actually have to do the lower dosing. 5 milligram twice a day, I think
Yeah,
also
that's
depends on what you're
yeah,
treating.
that's what I just like to know. Like, should we like continue with whatever the patient's like getting, or that half of the dose that is mentioned here? That's
So
what.
let me make sure you know. So for atrial fibrillation, the dosing is more standard. It is for pulmonary embolism that the dosing is adjusted.
Okay.
Yeah, for atrial fibrillation, the dosing is 5 milligram twice a day. Yeah, so it also depends on what has been studied. For pulmonary embolism and DVT, the dosing is adjusted based upon creatinine clearance.
All right. Okay.
Sorry,
Thank
what we
you.
say.
Yeah, sure.
How often do you use statins for all those medications?
So very great question actually, and I could not find any data where cystatin C has been used for drug dose. So because cystatin C is the newest kid on the block now, right?
Yeah.
So Dr. Kao's question was, has anybody used cystatin C for drug dosing? And the answer is not yet. As of now, the CKD equation between creatinine is what is the most widely available. Like in smaller hospitals, cystatin C is actually not even available, or it's a sent out test. So that's why the FDA, as of now, is not recommending the CKD epi cystatin creatinine equation, even though it is more accurate for GFR estimations. Yeah. What do you think, Ahmed?
Thank you, Doc.
Okay, thank you so much.
Thank you. Thank you.
Thank you. Appreciate it. Thank you, Dr. for coming.
Thank you.
I was like, there's no attendance.
I think
Everybody's in there. No, that was good. Yeah.
Tough topic. Make it, interesting. Yeah.
It's a tough one. No, but interesting.